All right, good morning, guys. We're going to get started in just a minute. Before we All right, good morning, everyone, and welcome to this meeting of the Primary Care Access Delivery and Payment Task Force. I'm David Seltz, Executive Director of the Health Policy Commission and proud co-chair of this task force. Welcome to this full meeting in person. We're so happy to welcome you all here for this last meeting of the calendar year of 2025 of this task force. We've been doing tremendous work throughout this calendar year, and we're excited to continue to make more progress here today. But before we get too far into today's agenda, I'm very happy to turn it over to my co-chair to make some welcoming remarks.
Yes, good morning to everyone. I realize that I've served on commissions and everybody in a commission is a commissioner, but this is a task force, right? So I realize that you guys are task force members, which means when I call in Christina, I should really say Force Severin. You have the Force Rabson. I thought you guys are force members, right? I like that. I think today is going to be the beginning of a very robust discussion. I think that one thing that I would ask people to remember and you guys are all longtime professionals, so you've done this. Sometimes it's difficult to know when you stay at like the sort of conceptual philosophical level and when you delve into like particular wordsmithing, right? And just remember that it's very tempting to dive into the wordsmithing. But also remember that we are actually not legislators, except for two of us here. And whatever our recommendations are, when we have our recommendations, that's taken up by the legislature and they do some of the wordsmithing. And if something is controversial enough, they will resmith the words, right? So just try to remember that when we get into these intense debates that can be sometimes very technical, that to just remember that, to try to remember, is this the place where I want to fight for this, or do I want to be able to give some high-level conceptual guidelines that would guide the legislative teams as they're actually writing the words? And I think it's a difficult thing. I always struggle with that, particularly when I'm talking to my kids. It's always hard to know when you're talking about concept and when you're like, I don't like her, you shouldn't date her. But so like you sort of have to like go sort of between the two. So I just ask for you to like just pay attention to that. Otherwise, David will never be able to get to the end of the meeting with it. No, he's a deliverable. He's in charge of delivering. But that being said, I'm looking forward. Like I know what I know, but it can be pretty limited. And so I think one of the nice things about this task force is I get to hear sort of different perspectives from your own area of expertise and your own perspective on society and the crisis in healthcare and in primary care that we face. So just try to balance those two things. It's a difficult thing that I'm asking, but I'll turn it back to David.
Great. Thank you, Mr. Secretary, and thank you for your continued steady leadership on this issue and for the continued prioritization of the Healy Driscoll administration on this primary care issue. And for the legislature's continued interest in this. We have been working with a lot of urgency on this issue, and I think a lot of urgency is needed on this issue. This has been the 12th meeting of either the full task force or work group of this primary care task force since April in just 8 short months. And I feel like we have made progress. I feel like we have really delved deep on a lot of different topics and really started to shape a vision for what primary care could look like in Massachusetts and what it should look like in Massachusetts. I feel like we've balanced in many ways the need to have very specific deliverables and recommendations that the legislature has asked of us, while also having the space and time to have those broader conversations about a vision for primary care and what that means for the workforce and what that means for patients. And so I hope to be able to continue that balance of different topics and conversations here today in this agenda. But before we dive too far into the agenda, we do have a bit of business to take care of, which is the approval of the minutes. And so this is the approval of the minutes for our last primary care task force meeting, which was held on October 29th. This was a virtual meeting, but because we are here in person, we do not need to go around and do a full roll call. We can do this by a call of the yeas and nays. But first, I will ask if there are any comments, edits, suggestions to the minutes. Seeing none, I'm happy to entertain a motion. Thank you. All right. A motion to approve the minutes by yeas?
Yay.
Nays? Any absentations? Great. The minutes are approved. All right. As I said, I wanted to return to the framework that we had in our last in-person meeting, which was back in September, when we were able to move forward our first deliverable on measuring primary care spending, where we spent the first part of the meeting really focused on that deliverable and were able to gather feedback on that. And then the second half of the meeting where we're able to engage in kind of a broader conversation. Hope to be able to repeat that kind of same dichotomy here today. The first part of this meeting, we are going to spend some time on two of the deliverables that have been legislatively asked of us today to make some recommendations on. And then later in the meeting, with time permitting, a conversation again around setting some goals for a vision of primary care reform and how we'll know if we've been successful. So with the two deliverables that we want to talk about today, first, we were able to share these draft recommendations with the task force members, the force members, ahead of the meeting, and on the two deliverables here around establishing a primary care spending target and developing a standard set of data reporting. And really, we developed these draft recommendations based on the conversations that we've been having here in these meetings, the conversations that we've been having with different policy experts, and also informed by what we have observed in other states in terms of legislative proposals, and of course, the legislative proposals that are before us in the legislature today. So our goal today is to gather additional feedback from all of you and your input and your reflections on these proposals, have an opportunity then to incorporate those into these recommendations and to continue to make progress on these deliverables. So I thought we would actually go slightly out of order with the two deliverables. And this is just a little bit of maybe how my logical brain works, and start with deliverable number 3, which is around establishing a primary care spending target. And then move to the data reporting, which in my mind is really around tracking that money and making sure that the money that we're setting that spending target for actually makes its way to primary care. So I won't belabor too much the impetus for why the legislature asked us to think about a primary care spending target. This is, I think, well known. We have talked about this many times, the underinvestment in primary care in both Massachusetts and the United States in terms of the proportion of spend on primary care as a proportion of total medical expenditures, especially when we look at the United States compared to other countries that have high-performing healthcare systems with a foundation of primary care. Those countries tend to have percentages that are more in the 15 to 20% range. And so many states have set goals. This is not a new concept around setting a primary care spending target. We reviewed what many of those other states have done in a previous meeting. We had Chris Kohler come and talk about what many of those states have done and some of the design principles that went into the different states' initiatives. And so Chris Kohler also laid out some of the different kind of complementary pieces that go with a spending target. How do you do the data reporting? How do you think about accountability? And we, at a previous couple meetings, had some conversations and feedback from all of you about what we might want to propose in terms of a recommendation here. I will just reflect for a moment and say that setting goals in public policy is not a new thing. We in Massachusetts set goals all the time. We set goals in terms of affordable housing and clean energy. And it is a way to motivate collective action, a way to motivate change both by government and private actors to identify something where a market has not achieved the goal that we need as a public society. And I think as we look at what our healthcare market has done in terms of primary care, it has not achieved the goals that we need and achieved the values that we need in terms of primary care. And so goals are one way that we can nudge the market in the way that we think it needs to go. And so the goal in it is not going to change primary care in and of itself. I think we all know that there are many other complementary goals that are going to be important to change the workforce and the patient care. But this is kind of a fundamental rebalancing of what we care about and value in our healthcare system and saying we need to nudge our system to care and value primary care at a different level than it does right now. And without government setting those goals and the private sector committing to them, it's not going to happen on its own. And I think we have the track record to understand that it won't. So with all of the discussion that was put forward, this draft recommendation that we're going to talk about today recommends that the Commonwealth take bold action in setting an ambitious primary care spending target with a timeline that reflects that urgency and aligns with the practices that have been put forth by the policy experts and legislation passed in other states and the pending legislation in Massachusetts. And if achieved, would put us at the absolute forefront among states in terms of both the target and the timeline for achieving this rebalancing towards primary care. The draft recommendation establishes a primary care spending target equivalent to doubling the share of primary care spending on primary care as a proportion of total healthcare spending, or 15%, whichever is greater, within 5 years. There is, I think, an understanding here with the either or that we may not know exactly where our starting point is once we do the calculations of the baseline in 2026. And so there are still some decisions and whether how that calculation is done. And there was concern, I think, among some task force members that there might be some incentive to weight the measurement in such a way that it could be easier to hit just a static target. And so I think this kind of or greater than is trying to kind of cover both bases in terms of saying a 15% static target, which is, again, equal to the most aggressive in the country, and a doubling of which would then say, even if our starting point ends up being something like 8%, that we're ensuring that we're meeting that aggressive goal. This task force has mentioned repeatedly that we need to be sure that as we seek this goal, that we are keeping in mind the healthcare affordability challenges and crises in this Commonwealth. And so a statement here that this increase in primary care spending should not increase the growth in overall healthcare expenditures, nor lead to a net increase in health insurance premiums. Similar to the recommendation that we had for deliverable number 1, this recommendation leverages the existing expertise of the Commonwealth and leveraging our existing infrastructure of independent agencies that have expertise in looking at and examining healthcare spending trends, looking at data and overseeing and monitoring trends, and would recommend that the Health Policy Commission and the Center for Health Information Analysis and existing data reporting structures be used to oversee this initiative. We include a statement that the increases in primary care spending should be prioritized to support the adoption of innovative payment models that support the 4 pillars of primary care. In this particular part of the recommendation, we acknowledge that is still a deliverable that this task force is working on, which is deliverable number 4 around innovative payment models. And so it references that particular deliverable. And I think once that will be at our next meeting that we would, I think, spend a little bit more time on that. And so, once these deliverables all come together, there'll be some, I think, kind of reconciliation of some of these internal references, but wanted to acknowledge that it's not just increased spending, but increased spending towards a change in the payment and care delivery, and that there should be accountability, and that accountability should apply to both payers and providers. We also include a section in this recommendation around complementary goals for reducing administrative expenses. I think we heard at this task force many times that I think to many of the task force members' credits who said increasing the spend on primary care is all well and good, but please also think about reducing my administrative expenses. And that is equally important as I think about balancing my business and the structure of my practice. And so we wanted to recognize that important thread here in this section by mentioning a number of those different potential opportunities. And here to reference future deliverables on, again, payment and care delivery changes, as well as deliverable number 7, which our workforce work group is working on, which is around improving the working conditions of primary care. So I went through that pretty quickly, and I will stop there. And would love to open it up for discussion and feedback on this draft deliverable and the component pieces that we've included for your consideration today. Senator.
Thanks, David. Thanks, David. This is great. This is great. I have a question. I'm not clear why the page 12, that deliverable, I'm not sure why isn't that on the draft primary task force recommendations. How is 12 different from 11 in terms of why it's not one of the major deliverables? See what I'm asking? Is this a continuation of 11? Because all of this reducing the administrative expense and burden to me seems to be absolutely one of the major focuses of this primary care task force. So I'm just wondering, is it separate for a reason, or am I reading this wrong? And it is just a continuation of 11.
So yeah, if members in your binders, you have the full, if you go to the tabs, you have the full draft recommendations. The way that we had included it here was this is part of the draft deliverable for this recommendation. And we included it as a section in terms of complementary goals. And so here it was to say, this deliverable focuses on setting a primary care spending target. But in doing so, we want to recognize that there are important complementary goals to that the task force wanted to recommend and make sure that we're including here, and acknowledging that there's going to be more work to be done in terms of further identifying and making more specific recommendations in the future work of the task force, but didn't want to go without those being recognized in this deliverable.
I kind of sort of understand. I guess what I would say,
Yeah.
I guess what I would say is that I would argue that a major deliverable of this is to reduce administrative burden in all of its glory. So we may have to go further to define that, which we will probably have to do with all of these, but that just to me absolutely belongs on this first page with a nice blue cover that says reduce administrative burden and complexity. So I would like to see it right up there in one of the major pieces. So that's my.
Thank you. And I think the thinking is that is really deliverable number 7 is around what our recommendations are going to be around reducing administrative burden. And so was not wanting to jump ahead on that specific one while recognizing that that is going to happen and is going to be part of the work.
I would just say one more thing.
Yeah.
We can't say it enough.
Yes, that's. Barbara Robson.
Thank you. Appreciate all the staff's work on this because it's coming together nicely. I have a question or a comment about the 5-year expectation and the 15% or the doubling. I don't think we can wait 5 years. I think every year we have to see directionally where things are going because it's clear from the dashboard that MHQP and CHIA have that every year primary care spend is going down in most of the payers. So the idea of saying, okay, we'll wait 5 years and voila, it will double. It's going to need some intervention year by year. So I would suggest that.
Thank you, Barbara. And I would point to, and the slides are kind of a rolled up version of this. If you look in the deliverable itself, under the designated agency section, we state HPC should establish annual measurable improvement targets to meet the primary care spending target. These targets should apply to both payers and providers. I think the thinking here is that HPC is going to set annual targets that we are tracking our progress on an annual basis. So it is not something where we set a target and wait 5 years to see if we've hit it. It's annual and that the accountability is being measured on an annual basis.
So what will the annual targets be?
I think the thinking is that once we have our baseline, we'll know what our target is that we're trying to hit, what that doubling is, and that HPC would have the authority then to say, okay, here's what the annual targets are going to look like, and how are we measuring and meeting those along the way.
Thank you. And I would just say, given this difficult environment we're in, where everybody's broke, grabbing money from anywhere is going to be particularly challenging. So, there should be a forum that talks about the rebalancing that you talk about. And I'm not sure what that forum is where you make those decisions. Is that the legislature? I don't really understand how we can say, okay, it's gonna, we get this and where does it come from?
Barbara, and then
I completely agree with Barbara about having a glide path that's well-defined. And I think it is reasonable to try to also establish front-loading it a little bit because of the crisis that we're in. I think it's a little problematic given the fact that most of our contracts are at minimum 2 years, sometimes 3 years long. So to make some of these adjustments, I think that one of the things we have to look at is not taking money away from clinical care, but taking and support that we give clinical care, but taking it away administratively. My sense, if you look at many of the systems that we all work in, is that there are many, many administrative layers. And I'm well aware that when you look at hospitals that are in trouble, you see they lay off the administrative people first appropriately, but care doesn't seem to be, it doesn't change the care. And that's where we have to look for the dollars, not on the clinical side, but on the administrative streamlining. And that's where number 7 will be really important. Thank you.
Thank you. Christina, and then I'm going to swing back around this way. Renee.
On the enforcement, not the word that's used, so pardon me that I'm not using the right word, but the oversight. In observing the creation of the HPC and the work to date, it's been really great in data collection, data reporting, convening, talking about really important issues like healthcare trends. It hasn't yet been successful in having being given enough regulatory enforcement authority around health systems, for example, health plans, controlling cost trends. So one of my concerns is I'm not interested in word smithing, dear secretary, but some language around an enforcement mechanism that actually has consequences that will either motivate carriers and or health systems to meet the target or have consequences that are consequential enough that they will want to stay motivated to meet the goals.
Thank you.
Dr.
Um, thank you. So I appreciate everyone's comments so far. It really feels like everybody's kind of fine tuning this document. And I think it needs to be said that this document that has been created by your team is really extraordinary and gives us the opportunity to pass historic legislation this session with these concepts provided to the legislators. And I particularly appreciate you mentioning the idea that we're not trying to increase the pie. I know this is something I've talked to Chairs Friedman and Lon about, and that they feel very strongly. And Force Member Hurst also has talked about this, that the pie is already too big. We're not trying to increase the pie. We're trying to stay within the pie, not trying to raise premiums. So I think that's an important thing. The doubling plus the benchmark of 15%, both, I think, is a super important concept. The doubling piece addresses the existential crisis that pediatricians are facing with their particular situation. And so I think that a lot of things are great here. I have four fine-tuning comments, and I'll try and stay brief. The 5-year ramp, my understanding in reading this document was that there were benchmarks each year and that it's a glide path over 5 years and that there would be accountability and legislation. We're recommending legislation that does have teeth that enforces this. And so that's good news. With the crisis that Barbara Rapson was mentioning, I'm wondering if 5 years is too long. In the 3 primary care bills, I believe I'm correct in saying that all 3 bills talk about a 3-year ramp, which I know is very aggressive. I wonder if thinking about 3 or a compromise at 4 years just worthy of consideration. The second comment is that when you talk about a doubling, that I think it may be worth being explicit that you're doubling the percentage and you're not doubling the numerator. If you double the numerator, it doesn't account for inflation. I'm pretty sure that was the intent anyways, but having explicit language around that may be helpful. The third comment is that in the accountability section, accountability is so important, and what you wrote was important. An additional accountability piece is that what happens, and this is something I learned from my colleague, Dr. Rapson, is that ACOs and systems, that money that goes to primary care will often get stuck at the system level and will not make its way to the primary care practices and, most importantly, to primary care patients. And additional language of accountability is in our, I think, at least one, if not all 3 of the primary care bills, talking about how 90%, 95% minimum of the dollars allotted to primary care should get to primary care, with a state entity having that same enforcement accountability around that 95%. The last point I'd like to make is that let's say we hone this document, we pass legislation, and there we are, excited about our 15% and so on, except what we've just passed in that instance is only applicable to fully funded plans and not the self-funded plans. In Massachusetts, we have 4 million commercial patients, 60% are self-funded. That's 2.4 million people who wouldn't get to benefit from this amazing work that we're all doing. So when you list additional policy considerations and you have a list of different ideas that could be worthy of consideration, I would add to that list the establishment of a state-run primary care stabilization fund. What that does is it bypasses ERISA, includes the 2.4 million folks. It also is a dramatic decreaser of administrative burden that Senator Friedman appropriately pointed out being a priority. Thank you.
May the force be with you. I had to. I am just here to sort of piggyback and comment on what folks have been discussing. And I think one of the areas that's critical is the timing that the Barbara's mentioned. And it is critical that there be an impact on primary care practices day one. Yes, we can ramp things up. But one of the big areas that I'm going to continue to hit is marginal cost. Decrease the amount of money my organization has to spend in order to deliver care. You do that, hopefully Mr. Hurst, his folks won't have their insurance premiums go up as quickly or at all, because if it's going to take this much money to fix primary care, if you want it all to be revenue, that's going to hurt. If you let some of it be reduction of expenses, boom, we get there quicker. So that's the things we have to think about. How do we reduce the expenses in delivering care? When we do that, we get to a successful primary care system for our patients, for the insurers, for the small business folks. We get there a lot sooner.
Question, clarification. Are you talking about administrative burden? Or are you talking about deregulation?
I never talk about deregulation. That'll just get you cut. No. What I'm talking about is right now I pay 6% of my revenue for some people I never see to talk to insurance companies and beg them for money from my organization. I would like to just send in a list saying I am seeing 25,000 patients, pay me PM, and let us do the work.
Here. I think we have. I think you didn't turn your thing up. I'm sorry, Martin. I think you're next, and I think can't remember who came first. But we'll always favor the left side.
Yes, I will.
Dr. Martin, go ahead first.
So sorry, left hander, I'm sorry about that. It's very brief, I apologize. In the risk of wordsmithing, but in the spirit also of our philosophy, this is a masterfully written document. The one word I think that doesn't represent the spirit of what we're doing is that it's ambitious. Ambitious to me implies over the top. And yet this is ambitious in the way that we are right-sizing something and rebalancing something, which are words that are used elsewhere in the document. So I just ask if we reconsider the word ambitious, because if I were a legislator looking at that word, I'd say, why be so ambitious? But in the end, we're actually doing something that's life-saving for the primary care system. And something that works toward Dr. Critchlow and Dr. Altman also, the idea that the stabilization fund does resolve as a policy consideration many of our concerns about first dollar helping on day one. So thank you for your consideration of that also.
Thank you. So I want to appreciate the boldness as the and in terms of the percent target spend and the doubling of a percentage. I appreciate that from a pediatric perspective. One point I would like to highlight is if this is going to be cost neutral, which I appreciate, and we talk about one pie. This happened, a few years ago with the RVUs being changed for coding purposes, and in some organizations, the RVU payment went down for primary care and for the cognitive specialists while keeping it cost neutral so that the proceduralists still maintained a higher level of revenue. So sometimes it doesn't always work out that way. My point being that in these percent spend increases allocation, that it's not looking at the whole pot. Pediatrics takes a very small part of our healthcare dollars, but a large part of what pediatricians do is preventative care that is leads to lifelong population health. And so that percentage, if the target is, we're going to make up numbers that I shouldn't be doing on the fly. I've seen other data that says that pediatric primary care spend is say 20%. Sometimes I've seen other numbers say 9%. But if we go to 20 or 50, 40%, however we do it, and most of that money is shuttled over to adult patients, then, pediatrics is still left back where they are, which is chronically underfunding for kids. We have a higher Medicaid mass health population and thinner margins even than on the other side of primary care. So just want to be mindful that if there's a way in this to be very specific, I know there are other potential areas. I think Mark talked last time about behavioral health, and I don't want to get into that, but I know that when you're 0 to 18 or 0 to under 19, it's a different set of numbers, and we need to just be mindful of that percentage. And that would keep our practices live and pediatricians in the workforce.
Thanks. And the conversation is good enough. I think David and I made the executive decision to continue going for at least another 10, 12 minutes. So we'll go with Sarah, Mark, Suzanne, Barbara.
Thank you.
Oh, John. Okay.
Definitely think these recommendations take the right approach and in the right direction. I want to underscore a couple of points and then have ask a question. So I want to just underscore and reiterate some of the points about the importance of ensuring that the recommendations apply to both payers and providers. I think this is critical in ensuring accountability, both in terms of increased investment requirements, but also this question of cost neutrality. It's really important to hold the entire system accountable. So appreciate that that was included. In terms of the timeline, I know there's this discussion around whether or not that's too steep, not steep enough. I think it could be steep without really strong mechanisms to ensure cost neutrality. So one question that I had is whether or how other states have been able to achieve that in reaching their primary care spending targets. 5 years, especially given the length of time that contracts are in place, 2 to 3 years, may actually not be as long of a time as we think in order to ensure cost neutrality. So I think we really need to balance those goals and ensuring that this really meets both goals of cost neutrality and new investments. And just can't underscore enough the importance of ensuring that it is cost neutral. We have an affordability crisis. At the same time, we do have the concerns about access and availability of primary care. So employers and consumers are already facing really strong and intense affordability challenges. So that can't be stressed enough. And then look forward to the conversations around additional requirements. We believe that these new investments should bring about additional transformations, medical home models, ensuring that we have more team-based preventative care. So understand that that's a future deliverable, but we think that really needs to be linked in terms of new investments.
Thank you, Sarah. So Mark, Suzanne, and Barbara, and then John, and then.
Yes, thank you. I think this is really well put together. The pairing of the sort of absolute threshold with the doubling is critical. The doubling is probably where that saves us. 15% of what is always the question. We don't have primary care spending defined yet. So it's kind of an arbitrary number. And I always worry we can define our way there, or other changes can happen that get us there without actually improving things in the way we all intend. With the doubling, I think there's a couple principles maybe worth mentioning in here without getting into minutia. One is the doubling has to be with a well-defined anchor year and a stable definition for that doubling. Definitions are going to change over time because if for no other reason than billing codes get updated and a lot of other things get updated in the environment that are going to change the definition necessarily. And that's why we have that extra technical advisory group that we talked about in deliverable 1 to manage that definition. That just needs to be applied equally, that exact definition, in both the baseline year and the 5-year target year. Otherwise, if you run the risk of measuring something in like yards in year 1 and feet in year 5, and it's an invalid comparison. The other point I was going to make is premiums are called out here as something to watch for making sure the cost doesn't go off the rails. That's good. I would expand that to include all out-of-pocket costs as well. I don't want to only focus on premiums here because we know that out-of-pocket costs are rising as a consequence of the bind that employers are put in as we see overall rising TME. That's it. Thank you.
Thank you. Mark, I was actually about to make a similar point about premiums and out-of-pocket costs, so thank you very much for that. And I also just wanted to reiterate something that Brenda said, because I'm assuming this doubling and the 15%, which I appreciate that you're looking at both of those, is in the aggregate across payers and provider systems, and we'll probably get to the more of the compliance and reporting later. So wondering if this framework does not add adding administrative burden, but looking at the pediatric piece, I think is really important to make sure there's not a reduction or no more investment in pediatrics, or even on the other end, if you're saying, okay, we're going to use our pediatrics to meet the goal and we're not going to invest in older folks, right, who might have a smaller percentage in pediatrics. So it could cut both ways. So just want to make sure that's still under consideration. That's it for now. Thank you.
Thank you. I wanted to follow up a little bit where Mark started in terms of the definition. And I know that in our first meeting, I think when, one of the meetings, when Chia presented sort of how we calculate primary care spend, there were some questions about behavioral health and not being included, maternity being included. I mean, there were some adjustments that we flagged, Medicare fee for service, for example. And I'm not sure when we get to our base year, like the attention that, who does that shuffling around? Like, how do we decide, okay, for primary care spend, we will, take this and that, there's just some decisions to be made. And so I'm not sure where that happens, whether Chia does that or there's an advisory group or what, but I think that's really important in terms of how we figure that out.
So we did recommend a process for that in deliverable number 1.
Which is this technical group. Okay. And so, because just as an example, in Oregon, when they set their 15%, all of a sudden everybody met their target and there was no more money spent on primary care. So there's ways that, people can do this. So the other thing I just wanted to mention to Renee's point about, sort of there are administrative costs, we've got to pull them out. We just have to be careful we don't throw the baby out with the bathwater. I mean, we need accountability in our system. We need quality metrics. We need transparency. We need to be able to see what's going on, so that we don't want to go backwards in terms of that.
John? Thank you. First of all, I want to say thank you for the healthcare affordability bullet. I think it's good. I just question whether should it be beefed up a little bit? Should ensure. Maybe it should be, you put in the word statutorily ensure. I just worry about, aspirational goals, just like the HPC benchmark, which obviously has not been followed for the last decade or so. I think the message needs to go to the legislature that you need some teeth behind this, or they're going to exceed. Premiums will go up, expenditures will go up. And I don't know if it's just adding a word or giving examples of how you do that, like maybe statutorily freezing and setting the benchmark for 5 years during that transitionary time and prohibiting any contracts which exceed that benchmark. I mean, something, that really makes sure that it's going to happen. Our goals become reality, and that small businesses and premium payers and taxpayers are not spending more money, 15% more to cover the goals.
Thank you. Fascinating and great work, as others have said. I'm interested in, it's going to sound like heresy or dreaming, but in the first point there, I'm interested in whether we would want to add a phrase. I recommend adding a phrase in the eventuality that healthcare spending, the denominator, goes down. I did say down, and I'm not living in a dream world. I know many of us wish healthcare spending would go down. And in particular, I'm thinking of an earlier conversation we had around whether to include pharmaceutical costs, because pharmaceutical costs is skyrocketing. Certain drugs that are recently produced cost incredible amounts of money and do incredible things for patients. And there's a lot going on in the US now around drugs and the FDA. I don't think we have a crystal ball as to what direction that's going in the near term or the future. So I would, and further, I can say as a practicing primary care physician, those incredibly expensive drugs that are magical are not within the purview of a PCP to prescribe. They're for very sophisticated subspecialists. So they won't affect the day-to-day practice for a primary care physician, but it would be an unintended consequence, I believe,
if these two percentage things, percentage total and 15% and such, if the available amount of dollars were to go down because pharmacy costs are somehow decreased, then the PCP portion would also go down. And that is unlikely to be what our intended goal is. So I wonder if we could add something that sets a floor for a decrease. And many will look at it and say, oh, decrease couldn't happen. Great, then it won't hurt to have that in there. But if it should happen, an example, recently insulin, right? Insulin cost whatever, I mean, unbelievable, right? And then insulin came down closer to affordable. So I'd like us to think about that. Thank you.
And appropriately enough, the last comment in this section will come from Chair Friedman.
And this is incredibly helpful to, certainly to me, in terms of what the legislation would need to look like. I have 2 points. I was going to bring up pharma, but something very different. I think it's really hard for us to continue to have conversations about bringing costs down for PC, for specialists, for anything, and not include pharma. It just, it's like taking both hands and tying them behind your back and say, you know, go bat this ball, right? Go play baseball. And so I think we really, part of what this group has to do is, while it is somewhat not completely directly about delivering primary care, we have to talk about it. And I think we have to look further into how we recommend pharma play a role in this particular effort, because they are a driver of these costs, and they are the largest right now driving costs. So I would argue that. I would say to you, you know, GLP-1 drugs are a perfect, you know, they're the poster child. So we have to, I think we just have to put that on the table. And I know that that's not an easy thing to do, but I'm all absolutely 100% in agreement that we need to have real enforcement in this, and we have to give that enforcement authority to somebody like the HBC in order for this to work. And if we don't do that, we just can't get this done. And then the final thing is the primary care spending target. Having learned from the benchmark, we have to be very, very explicit that this is an aggregate and that we are willing to have different outcomes or different measurements for different types of, you know, of care. So the aggregate should be increased to 50%. But just as an example, we can't give all the money or have all of the contracts with BI Lahey or MGB or something where everybody else ends up getting the sort of pieces of crust at the bottom of the pie. So, and I think that that's one of the things that we weren't, while the cost trends is an aggregate, we somehow forget that, and we don't give the power to say, well, yeah, this is the aggregate, but how should we change this? And not everybody was created equal. So I would add that piece to it as well.
30 seconds.
I'll take 15. I think that's a great point, and I'll echo the comments from everybody here about this being a very solid set. I think it will take some care and attention to make sure that we create an aggregate standard, but still be able to test it on an individual basis against individual players. And I just want to make that comment. It'll be important to do both of those things, because we're able to do that in the DOI space in terms of premium review directly. We need to create a mechanism that's fine-tuned enough to be able to do it at the HBC level, but still have it be an aggregate target.
Well, thank you, task force members. You have provided a lot of incredible feedback here. What I did not hear was a strong objection to any of the component pieces in this deliverable. What I did hear was many suggestions for improvements, for some clarifications, for additional enforcement. And so I think we have an opportunity to take this back, make some changes that reflect the conversation that we had today. I don't know if maybe ambitious is not the word, maybe it's a necessary goal. So I'm going to move us to this second deliverable that we want to discuss today. And so in our first deliverable, we have recommended that Massachusetts rely on the expertise of CHIA in order to have a foundation for measuring primary care spending. And that this was a critical first step for having a baseline understanding of primary care spending. And that the primary source of this information is information that is submitted by the health plans. This task force, however, had many conversations that this information solely coming from the health plans is really insufficient to fully understand the financial support received by primary care within our increasingly complex healthcare system, especially as provider organizations have different organizational structures that contract with payers and distribute revenue from both claims and non-claims payments to employed and or participating or contracting primary care clinicians. So we often refer to these mechanisms as funds flow, and this process is often internally developed and based on each organization's unique profiles and goals. And so we wanted to continue to talk about what would be some specific requirements to allow us to have that understanding of now having talked about a primary care spending target that would increase the amount of revenue and funding going into the healthcare system. How can we track and make sure that that funding is actually making its way to the primary care practices, groups, clinicians within these larger organizations? So as we have discussed this at many meetings, I think it has been confirmed through these task force members that there was, I think, wide consensus among the task force members that there was limited visibility into these flows of funds. We heard from Dr. Schwartz around how Mass Health has thought about this in terms of their ACO contract and some of the challenges that they've faced. And again, a reiteration for a need for some additional insight and transparency and reporting. And so we have put forward a draft recommendation for you today that does recommend additional reporting about the flow of primary care payments within healthcare systems, and that this would complement the payer reporting that was described in deliverable number 1. And that this information is necessary for the goals of promoting transparency and improvement and being able to track and understand that the increases in primary care spending are meeting the goals of the task force. So similar to primary care deliverable number 1, this recommendation seeks to leverage existing infrastructure that we have in this Commonwealth. We are very blessed in this Commonwealth to have a robust infrastructure for collecting information and being able to analyze this data. And so this recommendation would authorize CHIA and the Health Policy Commission to collect information on the flow of primary care payments within provider organizations as a required component of our current Massachusetts Registration of Provider Organization program, which I'll talk about a little bit more in just a minute. As part of this, that the HPC and CHIA should be directed to prioritize the collection of data and information necessary to understand the financial support provided to primary care practices within these organizations. And this would include information about the flow of funds within these organizations, as well as provider organization primary care accounting. And so what do we mean by this? For the funds flow mechanisms, really around information about the allocation and amounts of claims and non-claims payments to primary care groups within a larger provider organization. What is the mechanism for primary care revenue, the distribution of primary care revenue through various systems like IPAs, PHOs, ACOs, as well as larger hospital-based systems that have primary care practice groups within them. Are payments retained at different levels of the larger organization? What are the governance structures that lead to how these distribution decisions are being made. How are the distributed payments ultimately used by primary care? And is that a decision of the primary care group, or is that a decision of the larger organization about how those primary care payments are ultimately used at the primary care level? And with provider organization and primary care accounting information, it's really to understand the financing and accounting of primary care groups within a larger provider organization. That may not be the flow of funds, the funds flow mechanisms, but what financial supports are being provided to primary care, either directly or indirectly, within an owned or affiliated structures, what internal functions or infrastructure are being charged to primary care for primary care practices, how are employed physicians being paid, what amount of funding is being retained by the larger organization. And so really trying to understand through each of these different concepts, revenue coming into the larger organization, what is being retained at different levels, how is decision-making happening, and how much of that revenue is ultimately being in the control of the primary care groups at the end of the day, and what is that revenue being used for. And so part of that is about funds flow, part of that is about the internal accounting of these complex organizations. So these are complicated concepts. And so as was said, this recommendation recommends that we leverage the existing infrastructure we have in CHIA and HPC and this registration of provider organization program to take that next step in terms of developing what would be the very specific data specifications, what are the very specific questions to be able to collect this information. Importantly, as a principle that we would say is that in doing this, we would not be seeking to impose any administrative burden on primary care clinicians. I just want to say just a minute about the registration of provider organization program and why this, I think, is a great place to leverage an existing program. This is a program that we are collecting information directly from the 60 largest provider organizations already in the Commonwealth. We collect information about their organizational structure, their governance, their corporate and contracting affiliations, their clinical affiliations. So we are already collecting a pretty robust map and understanding of these organizations and who they're contracting with for whom. And we have already begun to collect some basic information about funds flow. And so adding more requirements in to be more specific about those funds flow requirements is a natural next step for this particular data and information collecting program. And so that is why we would recommend leveraging this particular program as the natural way to do this. This program, it collects it at the provider organization level. This is not about collecting information directly from primary care practices, right? So we are collecting this at the larger organization level. I think that's really important for everyone to understand. Because we are collecting this at the provider organization level and these organizations that contract on behalf of many primary care providers, we are ostensibly picking up the vast majority of primary care providers in the Commonwealth. 75% of primary care providers are in some way connected up into these larger provider organizations. What we don't capture here is smaller independent primary care practices. And I think that is actually probably appropriate because these are organizations that are not connected up into these larger organizations, are not contracting through these larger organizations, and aren't the subject of what we would think of being needing to understand what is the flow of money, how are they using that money, and to put an additional reporting burden on them may not be particularly appropriate. So this was our recommendation. It's written out. I'm happy to engage in some more discussion and feedback on this particular approach to ensuring that we have this important information.
Before I call on the people who raised their card, Christina and maybe Barbara, and I apologize if I offend anybody. It's just that I know that those two, you've had a lot of experience working in different types of complex organizations where you're tracking payments and you run an ACO now. Like what words of wisdom or advice do you have I must say this is the part this is the little bit that worries me the most. Like the worries me, especially when we talk about administrative burden and the ability to game the system. This is the part that worries me the most. I was just curious, Christina, then Barbara, since you guys have sort of been in, your hands were sort of in the dirt on this one, like what your perspective is.
And Mr. Secretary, is your question specifically about, are you interested in the intramurals that can happen where the rubber hits the road in these systems on funds flow to primary care practices?
Or how would you, if you were Chair Friedman and Chair Long, like how would you sort of design it to maximize the goals that we have as a task force?
Maximize the goals as established on primary care spend, actually making it into primary care practices and having consumers be the beneficiaries of those investments. I mean, I think I say this a lot, Ryan. I think the Mass Health program, and Ryan's been really honest about what's worked great, what's worked really good, and where some kinks may still rest. I think that with all of the regulation in Massachusetts, it probably has the most specificity around the requirement on getting the money into the primary care practice. Understanding that even with those requirements, there are loopholes and there are flaws. So I think trying to replicate what Mass Health has done on creating specificity of requirements that an organization have a funds flow document that can be produced that is synced up with the regulatory requirements of Mass Health of the Commonwealth of Massachusetts on how, in the incredible complexity of fund flows and ACOs and large system ACOs that go to primary care providers, you're also then going to have to deal with, and I don't have an answer here, but the myriad of complexity of how value-based contracts and how there might be puts and takes on primary care practice performance, positive, negative, play off against what was the budget based on the goal. And that whole complexity of reconciling what was the goal, the monies that ultimately end up in the primary care practice after all is said and done, on reconciling what the value-based contract might be with the carrier and how the primary care practice is tied into that architecture of funds flow, or is ultimately the easier thing to say, getting back to Wayne's point, that we don't really want primary care providers in the business of taking downside risk. Could be a radical departure of where we are right now, but that would be a cleaner way to say all of the intramurals can happen on value-based care over here, but primary care is different, and it's not an insurance business, and it's a wellness business and an acute care episode in primary care business. So that happens over here outside of this value-based complexity, and quality is in there because that's critically important. And so we have a goal and we can measure it, and it can be prepaid, but it can be segregated out from the rest of the complexity. If it's not segregated out, somebody can probably create the architecture of how all of those puts and takes work. Be incredibly complicated.
And Mr. Secretary, I would acknowledge that this recommendation does not include the data specifications. I think this recommendation tries to identify the larger buckets of information and some kind of examples of what that information is, the purpose of that information, and sets up and designates the agencies to do that work of creating the data specifications. And we specifically acknowledge in the recommendation that they should consult with Mass Health and learn from how Mass Health has done this. And we include some information about the Mass Health process here as a kind of a potential, I don't want to say maybe best practice, but a one that has gone the furthest in really thinking about this.
Barbara, Renee, Chair Friedman, Joe, Mark. Oh, and then Laura, Sarah, Ryan.
So I think there are a couple of issues that get raised that are really important. One, 25% of the care in primary care is done by independent private practices, and we need to be sure that in whatever we do, we support those private practices because more and more of those are falling by the wayside to be employed. And they're being employed by big systems. I've said repeatedly that the goals of primary care are very different than the systems that employ us. The systems that employ us are academic or for-profit systems whose goal is to get the high-end procedures and hospitalizations. It is not to provide primary care and wellness. And one of the things we need to be careful of, one is we need to be sure to support private practice. And I actually believe that we need to separate out how primary care is contracted. You can do it in the basis of a system, but primary care contracts should be different. They should not take downside risk. And the issue about pharmacy, I'm just going to take the opportunity to say, if I am doing my job as a primary care doctor and taking care of my patients, it may be, given the cost of medicines and particularly the newer medicines, that my pharmacy expense may need to go way up. What will go down is, for example, the number of hospitalizations for congestive heart failure and diabetes out of control. If I'm using the right inhalants every year, the number of COPD admissions should go down, but my pharmacy costs may skyrocket. So when we look at primary care, we probably need to measure them separately, because if you put them in together in the same bucket, it may skew the expense of primary care and also may skew what we're really doing and accomplishing. But I think that at the end of the day, if we really want to do this right, we're going to have to separate out primary care in the contracts that the health plans do. Because otherwise it's going to be very hard to manage and really understand what the overhead expenses are. Thank you.
Thanks. Well, just bravo from everyone. It was a good choice going with them first. Thank you, Dr. Secretary. So what I'm gonna piggyback on is a couple of things. Number one, primary care reform, we must be very clear that it's full stop separated from healthcare reform. And one of the things that we mentioned, your co-chair mentioned about not monitoring the independent practices. I'm going to push back just a little bit respectfully. We need to monitor the independent practices, because if we're doing this reform correctly, that number needs to go up. That's the thing. If we're doing this right, it's not, you're like, how are we going to track the money? I'll tell you how you track the money. You make it so easy for the Mass League of Community Health Centers to take care of patients and employ doctors, and you make it so easy for independent practices, folks to roll out of residency, and you're like, hey, you want to start a clinic? Let's start a clinic. You make it so easy that BI and MGB have to compete for those doctors. If they have to compete for those doctors, we're doing it right. The way we'll know that they're competing for those doctors is that we've made it easy enough for someone to start their own practice. We've made it easy enough for them. It's not going to be 25%. Honestly, I think we're in good shape when we have 60% of practice, either independent practice or community health centers. You pull people out of the big systems, because Barbara mentioned there's very different needs. It's like our alignment as primary care physicians, my alignment as a family physician is more with Mr. Hurst, because I'm trying to keep people healthy. We want to keep premiums down. So we do payment reform in a way that allows the cost reduction, that allows the administrative burden reduction. Sure, quality is very important signaler, very important. Make it easy to do the quality care. Make it easy to report the quality care. And we'll know that we're doing it right when the number of independent practices are going up. And as to pharmacy, the biggest thing that we can do immediately is PBM transparency. We do PBM transparency, I'll tell you, those stuff will start knocking itself down. Because how do you have a multi-billion-dollar industry that saves money? Okay, I'm done.
We'll go with Chair Friedman, and because we have to end at 11:30 and there's so much interest, I will be track of time, so I will be more generous today. You'll have a whole 2 minutes. Just so Chair Friedman, then Commissioner Coljo, then Mark, and then we go to Laura, Sarah, and then Ryan.
So that was brilliant of you to ask those guys. Couple of things. We have been working on this issue of how to track the money in my office alone 10 years, okay? And I think we need to be prepared to say and look at what you've heard from Barbara and Dr. Critchlow. We may not be able to answer this issue or address this problem by getting information from systems. We should very, very seriously look at how do we change the model. So, and you've heard some ideas here, but I think I'm not the brightest bulb in the lamp, but this has been something that has been so difficult to crack that I think we need to really focus on how we just change it. In the bills, they very much refer to looking at Mass Health as the model. We agree it's not perfect. It's by far incredibly interesting and incredibly successful by a lot of measures. So I think that's a great place to start. And then the other thing that I would just say is that as the person who is obsessed with private equity, we need to make sure that those little systems don't somehow roll up into big systems that are there for making the money. So that's why we've tried hard in that RPO to add more entities, or at least define what we're seeing so that those independent practices are really independent. So.
I listened with a lot of interest to Task Force member Severin's comments on the labyrinth that I think is real. I do think that the care and attention to trying to navigate towards a better path still makes sense, even though it might not be the perfect solution. It harkens back to, I think, member Altman's comments about understanding the numerator and the denominator. Otherwise, you're sort of losing the general bead. So it may not be perfect, but there's something there that maybe we should nudge to. And I think in our recommendations, we don't have to nail that down, but I think we should underscore the importance of trying to drive to that. At the same time, I do want to echo the comments about trying to foster the growth and success of independent primary care practices. And I do think that while we don't want to burden them with administrative requirements in terms of reporting, there should be an overall way to track that growth, for example, through other data that already exist. And we should have a metric specifically to that goal and express that firmly in our recommendations.
Thank you. And since Mass Health was mentioned several times, Ryan, I'll have you bump in and make a few comments, and then we'll go with Mark, and then Laura, and then Sarah and Julie.
Thanks, Cameron. I just wanted to go back, and I appreciate all of the recognition of the work that Mass Health has done, and it is not perfect. And I think one note of caution that ties these two deliverables together very importantly is enabling HPC, or the agency that is ultimately responsible for enforcing this, to define the data specs that will drive the accountability mechanism. We are not doing that as a part of these recommendations, which I think is appropriate, but absent more detailed data specs, we have a risk where on the plan and the payer side, we can very easily track the dollars. Once that goes into these large health systems that we are describing, that Christina very articulately painted the labyrinthine matrix of, we lose those dollars very quickly. And I think it will be much more difficult if and when we hit that 15% or a doubling thereof to actually track accountability at the provider entity level, going to practices and making sure that these dollars are actually landing in the practices, which is the overall goal.
Yeah, I agree. This is incredibly ambitious. It's probably the most important link in actually getting the money to where we all want it to be. I think it's fine not to, have the solo practitioners or 100% primary care organizations have to report. We already know it got there. Mission accomplished. It's those more complicated organizations that have a lot of specialists in hospitals where you have to be worried about this. So that focus is appropriate in my mind. A couple ideas to complement what's already here. One is to specify this should include all payers, not just those that are subject to the legislation, and I would include specifically traditional Medicare. The reason is that you can have a perfect system. Let's say Mass Health had a perfect system. I know, Ryan, you haven't claimed that, but let's say it was perfect. You knew exactly where every dollar was going because you tagged them with some kind of tracing compound, right? You know they're all going to primary care. Great. You don't know where any other dollars are going. And it's possible that the other dollars, the Blue Cross dollars, the Medicare dollars, the $0.32 are all being removed in exact proportion to those traced dollars from primary care, right? So it has to be all in, nobody out. That's critical detail. The other thing, I think just because it's going to be so hard to do, is to consider a complement that can start right away, which is to gather some data from the end user you really care about, which is the primary care clinician and the managers of the practices. Do a survey like, are you seeing any of this money? Has your budget gone up one lick since this went into effect? Because if you don't have that, you don't know how well your new fangled accounting system is working.
Thank you, Mark. Laura and Sarah.
Hi, thanks. Just 2 points, and I'm curious how this process around creating this reporting system, tracking all these funds, how that interplays with the concept of having the stabilization fund. Just that's a question about order of operations by way of something. It would be good to see some sort of language in here that would account for not just tracking at this large system level, but also having that capability of understanding what the impact would be for a stabilization fund. Because this conversation, like Christina, labyrinth was such a great word. This idea of how we can do this in the most simplified manner that's equitable and available at this large hospital system level, but also for small primary care practices like I have. So I think that that's a point, and I would like to see that somehow integrated into this. The other thing, I thought Barbara raised a really great point about what are we going to measure? We look at quality metrics all the time. Great. Can I control a blood pressure? Yeah. Can I get an A1C down? Yeah. But I think you need to also measure the fact that my patient was able to get transportation so that they could go to their oncology appointment. Those are the things that are really important. I also appreciate the concept of asking the front desk people or asking the providers at the practice level, the practice managers, and getting their perspectives. We also need the patient's perspective. And I think that it would be a great metric to say, how do you feel compared to last year? Same, better, or worse? It's a radio button that you could click. Very easy to measure. And I think that we need to make sure that we're bringing this back to the needs of our patient.
Thank you. Sarah?
Thank you. I want to echo a lot of the comments, but I raise a couple more. So on the RPO, so believe that would capture the bulk of this. Want to also underline Medicaid and Medicare are not included in that today. So I don't know if that's included as part of the right. Okay. Because that's really critical to track that downstream impact, not only on claims, but these nuances and non-claims that we've talked about in the previous report. Additionally, I think the definition of primary care in here is going to be really important. I think Mass Health is a good model. It's still very complicated, and we've seen the difficulty in trying to parse out what is primary care and what is specialty. So I know that is going to be part of a larger conversation, but that is probably the most critical piece here, is making sure that is included. And also, in addition to RPO, looking at updating CHIA regulations around hospital system reporting to also capture some of this. There are dollars that are spent at the hospital system level that may or may not be directed to primary care. So I think both pools of data would be really critical to make sure that we're capturing all of the information we need, both in terms of the organizational structure, but how funds are flowing down to the practice. So I would add to see if we could add that to the list of recommendations for regulatory changes.
Get the last comment before we turn it over to David. Close us out.
Thank you. I wonder if we could look at how inclusive we're going to be in these measurements. I've heard said that the largest organizations, largest 60 or some number, would be looked at, and the individuals who are not subject to contracting through those, I guess might be the right definition of them, would not be looked at. Those tend to be, of course, the smaller practices, the individual practices, the DPC, direct primary care practices, the concierge medicine practices. And I have a pause around whether an unintended consequence, I'm always looking for unintended consequences, right? Because this is all great work, right? So, but what could happen, right? So I worry about the possibility of a two-tier system. Health inequities is what I mean by that, whereby a bunch of us are scrutinized carefully to make sure enough, whatever that is, money is getting to primary care, or some more money is getting to primary care. And then other practices have money coming in from all sorts of places directly from the patients. So Dr. Friedberg's idea of getting all of the funds, so I hope that's going to include the concierge prices that patients pay. Those are usually patients of considerable means. And the DPC prices, which are much more reasonable, but still, I believe, coming from
30
people of
30
means.
seconds.
So I'd like us to look at whether we could unintentionally create a two-tiered system, which we, I'm sure wouldn't want. Thank you.
Thank you, task force members. I think as always, this has always been a labyrinth of a topic to go through, and the conversation, I think, reflects that. So I appreciate all of the comments here and the feedback, and by no means, I think, the suggestion that things that fall outside of the circle aren't things that we shouldn't care about or that we shouldn't be observant of. I think for this particular purpose and understanding the flow of dollars within larger systems was the primary focus of this. But we'll continue to try to fashion something here. So this has been a great conversation. We did not get to the second half of our conversation, which is unfortunate. But I do just want to highlight here that we were planning to talk a little bit about setting some other goals, and we talked a little bit about setting a spending target and understanding that just setting a spending target is not going to be necessarily the sole measure of success, and saying that if we hit that spending target, yes, we definitely achieved our goals of changing primary care. And so wanted to ask questions around what are additional goals or indicators of measuring success for this task force work. And just to want to highlight in that final bullet point, what are important metrics to measure success in health system structure, perhaps more independent clinician practices. So I think this is something I would leave you with in terms of thinking about in these different domains of patient experience, clinician well-being, population health, health system performance and structure. What are those indicators that we think 5 years out that we would like to see directionally changes in? And what might be those appropriate metrics that we would want to see 5 years out? We would have X% more of certain things or reductions in certain areas, so that we're seeing that as we're putting more money into the system, that money is actually delivering the changes that we want to see. So we may come back to this group over email and ask for some thoughts and collect that in a way that does not violate open meeting law, and help use that to structure and make some prioritizations for our work in the new year. With the 2 deliverables, we will take back this feedback today. Deliverable number 3 in particular does have a legislative deadline of December 15th, which is the primary care spending target one. I do think, given the feedback that we received today, that I think we could hit that target. We a lot of targets today, huh? So what I would propose is that we take the feedback that we received today, make appropriate edits reflecting the conversation, share that back out with the group, give you all an opportunity to review that, provide additional comment to us, and if there is kind of a general sense and a feeling that that is fine, that we would then, as we did with deliverable number 1, post that on December 15th as the deliverable from the task force. So Kelsey will be in touch with all of you on terms of the process for that. But I think we can get there, and I'm seeing some gentle head nodding around the table that suggests we might be able to do that. So I think that would be an incredible accomplishment. That is one of the biggest signature goals of this task force, and not ambitious, bold, necessary, and needed, and a tremendous statement from this task force to close out this year. So, Mr. Secretary, I'll give you the last word.
The only thing to follow up on what Dr. Mellon, I of course glanced at my phone while Christina was droning on, and the Health Affairs actually did an article on what's happening in the DPC realm, and as there's been an explosion in DPC and direct and other types of care, the percentage that's owned by the people who work there has been dropping precipitously as well. So it's gone down, like in the past 2 years, from 83% owned by the people who work in them to 59% now. Like, it's the new playground for private equity. So it was sort of just interesting that you mentioned that. Thank you. This was just want to reiterate what my co-chair mentioned. This was a really strong and a good discussion. And I'm looking forward to being able to deliver on our December 15th deadline. And I'm looking forward to the further work that we have ahead of us in the coming year. So thank you.